Hi, my name is Bashar Badran, and I'm an assistant professor in the Department of Psychiatry at the Medical University of South Carolina. Today I'll be speaking to you about MRI-guided transcranial focused ultrasound to modulate pain thresholds in healthy adults. This is data from our double-blind concurrent FUS MRI study. The question is, can we modulate pain with ultrasound? The integration of afferent pain signals are often described as sensory, cognitive, or affective motivational. All three of these pain pathways receive signals from pain fibers in the periphery, which relay up to the thalamus in the central nervous system. The thalamus has been a therapeutic target for the treatment of pain over 70 years, with early reports of the removal of thalamic neural tissue to assist in pain treatments, as well as DBS implantation in the thalamus as well. For this reason, we chose the anterior thalamus as the primary target for sonication, as it's the central node for pain processing in the brain. We recruited 19 healthy volunteers who attended 3 experimental visits in a randomized, sham-controlled, double-blind, experimental design fashion. Visit 1 consisted of the consent and the conduction of a structural MRI, which was used for targeting. Visit 2 and 3 were identical, except for the condition, active or sham, FUS that was received. Each visit consisted of pain thresholding outside of the scanner, the administration of FUS within the MRI scanner targeting the right anterior thalamus, followed by, outside of the scanner, final pain thresholding. We had 3 primary outcomes. The first was target engagement. Second, quantitative sensory thresholds before and after FUS by condition, active versus sham. And outcome 3 was functional neuroimaging, however, it's not presented in this talk. The experimental timeline is pretty straightforward for visits 2 and 3. Outside of the scanner, there is a baseline quantitative sensory thresholding, which is our primary outcome, followed by in-scanner targeting of the right anterior thalamus using the MRI console, pain induction paradigm, and 2 10-minute boluses of FUS. Afterwards, participants were removed from the scanner and QST was conducted again. This is our MRI-compatible FUS system built by BrainSonics, which utilizes an 80mm transducer pictured here on the right. Sometimes the 80mm transducer had too deep of a penetration depth, especially for participants with smaller heads and brains. So we often would use an acoustic standoff pad that can be tuned between 1 and 2 centimeters thickness that would stand the transducer off the skull far enough so that the 80mm fixed length would engage the target. The system is in the back of the MRI scanning room in what we call the equipment room and connected to a series of RF filters that allow for the administration of FUS concurrently in the MRI scanner. Visit 1 was a targeting visit where we acquired a T1 3T MP range image. This was then synchronized using BrainSight neuronavigation, where the transducer was connected to infrared sensors and trackers that allowed for us to real-time track where the transducer sits on the scalp and mark the optimal direction and target for a planned approach of administering FUS to the right anterior thalamus. Practically, this is what the sonication looked like. The transducer is fixed to the participant's head using a Velcro strap and an MRI-compatible 3D printed head holder. Participants had a hand pad to conduct some ratings and receive pain via MRI-compatible thermode. And the transducer has a fiducial so that we can plan the optimal trajectory in terms of angle of approach and penetration depth so we can confirm that we were on target. We subsequently built an open source imaging platform that allows for us to post hoc determine whether participants were sonicated on or off target. This creates a bounding box around the transducer, projects the sonication beam into the neural tissue, and then determines via green or red dots whether we engage the predetermined target, which in our case was the right anterior thalamus. In our case, 17 of the 19 participants were sonicated on target. And our behavioral data suggests that FUS reduces pain thresholds after 20 minutes of FUS in the MRI scanner. The pre versus post active versus sham interaction was significant, and this interaction indicates that in sham stimulation, thermal pain thresholds actually decrease by 1.08 degrees, whereas in the active condition, this reduction is only 0.51 degrees Celsius. meaning that on the day they received active TFUS, subjects were not as sensitive to the pain even after the 2 hours of the experimental visit. I want to say thank you very much, and if you have further questions or want to connect with us, feel free to contact us at our website at www.neuroxlab.com. Thanks.